Good evening, everyone, and welcome to the third Conversation That Matters series that we are running in collaboration with the HSE. My name is Caroline O'Regan. I work in the Institute of Leadership in the Royal College of Surgeons in Dublin. I'm very pleased to have the opportunity to continue our discussion about ethics in this COVID-19 crisis. This is a complex and sensitive area and is particularly challenging in this pandemic. I want to welcome our panel of experts, back with Dr. Miriam Colleran. Miriam is a consultant in palliative medicine at St. Bridget's Hospice and Naas General Hospital. I would also especially like to welcome Dr. Emer Ahern. Emer is a consultant in geriatric medicine working in Cork University Hospital. I'd also like to welcome back Dr. John Fitzsimons. John is a consultant paediatrician working in Temple Street and a clinical director for quality improvement. And I would also like to welcome to our panel this evening, Dr. John Bates. John is a consultant working with the University Hospital, and they're here with us this evening to continue our discussion about ethics in a more specific sense. For those of you who could join us on Tuesday, you recall we talked about ethics in its broadest sense and some of the learning that we have got from other nations. Its impact on patient care from a service level perspective and the shared decision making that needs to take place. This evening's event, we want to talk about specific situations of the ethics surrounding decision making for critical care and the guidelines from the Department of Health, WHO, and putting guidelines into practice in this COVID-19 crisis. Tonight's conversation will take about 40 minutes, and we're going to start with Dr. Miriam Colleran and Dr. Emer Ahern, who will discuss the ethical guidelines to support our healthcare people in this pandemic. And then we will move on, and Dr. John Fitzsimons will continue the conversation with Dr. John Bates, and they will be discussing some of the more specific situations of ethics which surround decision making for critical care. Miriam, John, Emer and John, it is lovely to see you and thank you. So Miriam, I would like to start with you. Welcome back this evening to join in this discussion. Thank you, Miriam.
Thanks very much, Caroline. The aim of medical care is firstly cure, but that may and will not be possible for some patients, sadly. On Tuesday, we discussed identifying with patients as individuals. From a palliative care perspective, if, based on expert medical opinion, a patient sadly is sick enough to die and the patient's medical condition is not reversible, our aim would be to help keep the patient as symptom controlled as possible and for the patient to die peacefully, naturally, and appropriately. It's never a case that nothing more can be done. More can be done, but it's just different. While the hope previously had been of cure, then hope becomes of optimizing symptom control and quality of life, and the hope that the patient dies peacefully, naturally, and appropriately. It is still hope, but the hope changes. There is a significant amount of evidence showing that the use of medications for symptom control in a palliative care setting, including opiates and benzodiazepines, is safe, and very importantly, it does not shorten a patient's life. In pandemic preparedness and ethical considerations, the World Health Organization and the Health Emergencies Programme have given us great guidance on the ethical issues involved in pandemic medicine. RCSI are kindly going to host a repository of the evidence and literature that we discuss in this series. In particular, this document recommends that the old system of first come, first served is not considered ethical. It's not appropriate in pandemic medicine. The Department of Health have also issued the ethical framework for decision making in a pandemic to guide and inform us as clinicians as well. I think it's important to say that as a palliative medicine consultant group, we are actively collaborating and sharing information with one another, as indeed are our palliative nursing colleagues. I have no doubt but that other medical colleagues and disciplines are also appropriately professionally sharing external to their organisations, and we need this sharing of knowledge and integrated approach during this pandemic. I am very grateful to my colleagues for this collaborative working. Dr. Mary Jane O'Leary shared the Cork University Hospital document with our group. I thought it was a superb document, and that has led us here to today. Emer, I have been looking forward to talking with you.
Thank you, Miriam. At the moment, because of COVID, there's a lot of interest in the media and from the public about escalation of care decisions. However, this is not new to any of us working in healthcare, and such discussions and decisions about escalation of care are really as old as medicine itself. I suppose what is new for us as healthcare workers is this disease. We know very little about it and what the trajectory of the disease will be like. But also we have never had to make decisions in the context that we would have depleted resources like oxygen or ventilators. And that is what is new for us as healthcare workers. We certainly, with respect to escalation of care decisions, for anybody who's been a patient in a hospital and had a conversation with a doctor, everybody has had these discussions about the benefits of treatment, the burdens of treatment, and the burden of the disease. And how can we give you a treatment that will give you the most benefit with the least burden? So a lot of people have already had these types of discussions with their doctors. And certainly we have national guidance about it as well from the HSE National Consent Policy and our own Medical Council Guide to Professional Conduct and Ethics. As a geriatrician, I, like everyone else, was watching the news and the television and what was unfolding in Wuhan in northern Italy. And certainly it scared me and it concerned me and many of my colleagues about what was happening. Also, I was becoming increasingly aware in the media of the incorrect language and the rhetoric that was being used about older people. I suppose this really was the sense of urgency that was created in Cork, really to come together as a group of clinicians to try and come up with a tool to support people making these decisions. And that's really what we have developed in Cork, really since, I suppose, in record time, because everything is in record time these days. It's really a tool that will support clinicians to make decisions about a person's care during this pandemic. And I suppose the principles underlying decision making must always be the same, and we must always revert to the core principles of shared decision making, even if in the event of depleting resources. And I suppose firstly, what I would like to say is that the circumstances surrounding care provided for any individual is entirely unique, and any decisions must be made on a case-by-case basis. We must always explore and consider what a person's goals are, their values, and what insight and information they have about the burden and benefit of diseases and treatment. And this must always be taken into account in this shared decision making. And what we would say is that all adults who come into hospital or who are admitted to hospital as an emergency and who are at risk of deterioration should have a multidimensional assessment. And this includes assessment about comorbidities, frailty, their cognition, what their own quality of life is like, and what their values and goals are themselves. And to use this information to establish a care plan that would include an escalation of care plan. And this is really kind of where we've kind of come about in Cork to develop this tool.
And can you tell us a little bit further about it?
So what we've incorporated, I suppose, in the media and in some of the documents that you've referred to, Miriam, there was an increasing trend to the incorrect use of age in terms of a discriminator for escalation of care. But also of concern to us was the incorrect use of frailty and frailty scales as a discriminator for escalation of care. So what we have in our document is actually included a multi-dimensional assessment of the person. And I think it's very important from the outset that when you are carrying out or when you are asking questions about what a person is like or what they were like, it's very important to base it on what they were like before they got sick, before they got COVID in this instance or any other illness. So it's really to be based on what they were like, we say approximate 2 weeks before their current illness. Because as you know, if anybody is sick with sepsis in a hospital trolley, they will look very frail and very vulnerable, and it's very hard to make decisions at that point. So what we have is included an assessment of their frailty using the clinical frailty scale, an assessment of their activities of daily living, so dressing, washing, showering, dressing, but also going to the shops and cooking. We've asked about their comorbidities and their cognitive status, and how all of these 4 things, all these 4 dimensions are impacting on them living their lives. So we use all of those and bring them together. And we also ask about how they would rate their quality of life. So for example, if somebody is housebound, they might be really enjoying and really rate their life as really good and have a lot of visitors. So it's very important to get that perspective. And so what we do is to use all these dimensions to plan an escalation of care then that is documented on the patient's admission. And I suppose what we have seen, I think this is, again, I would emphasize that this isn't new. This is care that we should always be giving, but we probably haven't been doing it adequately heretofore. And it really is something that needs to become part of routine practice, you know, going forward and even after COVID. And I suppose what we have found here on the ground here in Cork is that it has given people a tool to start the discussions early as a prompt. And also people are discussing amongst each other. So they're discussing with their patients, discussing with relatives, discussing with clinicians who know the patients better than maybe the first person who meets them isn't. And I think we're creating this whole multi-dimensional picture that is informing kind of what their care will be like during their hospital stay.
It sounds to me, and reading the document, you're describing really detailed, person-centered, holistic care.
Yes, absolutely. And I think that's what we all want to be about all the time, you know, and I think probably in this, you know, during this pandemic, people were initially panicking and, you know, the atmosphere was chaotic around the places. People were rushing to do things. And actually, when we actually brought this back and brought a structure to it, you could almost sense the kind of relief from colleagues that actually we're back to doing what we know best to do. And we can get back into this routine again of what we know best, because people are very used to doing this. It was just that the conversation had been deflected for a while and John might go into this later about kind of when resources are depleted. But certainly I think we always need to default to that initial thing. This is what we have been trained to do. This is what we're good at. This is what we just need to become part of our routine practice.
Okay. And how have you been finding it? How have the other clinical staff in the hospital been finding using it in practice then?
I think they've just found it very, very welcome. So we use it, I suppose, at our front door now. We're using it in our emergency department, and they have found it very, very useful. And also we have a separate kind of COVID stream coming into the hospital where we've used it as well. And then afterwards, the following morning, we use it as a discussion document then in terms of the handover of clinical care from the night staff to the day staff, and then at the end as well. So there's a communication. I suppose it's very important that the reasons why you make these decisions is communicated, is explained and communicated to all the staff that are looking after the patient. So even these decisions are actually even being communicated better. So, and certainly my colleagues would have said that we have met people now that we probably never would have met, you know, in our lines of work. And we've all come together really, you know, about this document, because ultimately it's something that affects us all.
Real collaborative working for the patient. Okay. I think actually we're going to move to the two Johns now for a little while.
Thank you, Miriam.
Thanks, Emer.
Thank you, Miriam. Thank you, Emer. I'd like to welcome Dr. John Bates. And I suppose, first of all, of course, I think it's to acknowledge obviously all of the work that goes on outside of the ICU, you know, with the likes of Emer and her colleagues. But John, I suppose if I can come to you, you know, there are some patients who clearly do need critical care and who are likely to benefit from critical care and ICU. Can you talk me through a little bit about how you and your colleagues use ethical ideas, concepts, principles in the decisions, I suppose, around the admission to ICU and then around some of the decisions when patients are admitted to the ICU?
Well, I suppose just to pick up on a couple of things that Emer said, we have a similar process here. We've collaborated with our physicians and people who would be referring us patients to kind of work out some kind of guideline as to how the process could happen. And again, just to echo what Emer has been saying, it is important that it happens when the patient comes into hospital, because one of the difficulties we have in ICU is that usually by the time somebody becomes critically ill, you can't have that conversation because they're too sick to have that conversation at the time. And this is something that we normally do. And every patient who comes in, intensive care and particularly mechanical ventilation is quite a high burden treatment. And it is crucial that the people who, you know, go for that treatment know what the risks and benefits are, and that they have a potential, it's appropriate to put them on, and that they have the potential to benefit from it. And that is the practice that we have at the moment. We're not out of resource at the moment. I suppose the two things about COVID-19 that are important is that there is the potential that we might get to an out of resource context in which the ethical decision making becomes different. It's something that nobody wants to get to, but it is something that we do need to have a plan for so that it can be done fairly if it does happen. You know, with regard to, again, as Emer said, this is all multifaceted. The assessment is all multifaceted. Chronological age, you know, while we have data in particular on COVID-19 that the mortality does go up as you get older, most of the other intensive care data would say that it's not chronological age, it's biological age, and that, you know, frailty and other things are just as important, if not more important, than chronological age. So, you know, the decision making at the moment, I suppose, there's just been a focus on doing what we normally do well, so that you know, patients get asked early on what their preferences are. There's a full discussion of whether or not they would benefit from mechanical ventilation, and that conversation is had before the point at which it becomes necessary. The other point, though, about COVID-19, and one of the reasons that the first come, first served model will not work and isn't appropriate, is that it's not like most critical illnesses. The average length of stay in an intensive care unit is about 5 days, but for COVID-19 it's a lot longer. It's 2-3 weeks, and that means that that's got two implications. I suppose the first is that clearly you're going to be in a situation where that resource is can't be used for 2 or 3 weeks. And the second thing is, certainly for older and frailer patients, that takes a lot more, it requires a lot more physiological reserve to recover from than the average episode of critical care, which is 3, 4, 5 days. So something like, you know, bacterial sepsis tends to get better fairly quickly once you get on appropriate antibiotics. Heart failure, things like that, you can get fairly frail patients in and out in a fairly short space of time, and that can be quite successful. COVID-19, which causes ARDS, really requires 2 to 3 weeks of mechanical ventilation. We know from the other ARDS data that patients who require prolonged mechanical ventilation for ARDS have significant functional impairment for about 5 years afterwards. So I think that's what's slightly different about it.
And John, I suppose at the moment it looks like we're very much still operating within capacity, but you've been giving some thoughts, and I know your colleagues have been, around some of the ethical frameworks and ideas that might be required if capacity becomes an issue.
So I suppose that's what we call the out of resource context, and that at that point, really, when you do not have sufficient resource to look after everybody who would potentially benefit from the treatment, that almost becomes a non-medical decision, if you know what I mean. That's kind of a community decision. It's not that you don't think the treatment is appropriate, it's that you cannot offer that treatment. So that's a very difficult situation to be in, and, you know, all efforts are being made at the moment with, you know, public health measures and with expansion of the intensive care bed capacity to avoid that. But if it does happen, there are some useful guidance documents. There's been some useful guidance from the Irish Medical Council, which I think was quite practical and very useful, and there's a useful document from the Department of Health as well. And all kinds of different things come into play then. Things like, having the patient, I suppose it really comes down to saving the most lives possible if you're out of resource. And at that point, you would need to look for the patients who have the best chance of survival. And again, it's difficult. It's something we don't really want to get to, but we might. So there are certain documents which offer good guidance. Apart from the two Irish documents I've mentioned, the WHO has a document on pandemic influenza. There are several from North America. There's one from Canada. There's one from Pittsburgh. There's one from New York, and they all use different kind of guidance as to how you would allocate scarce resource when you don't have enough of it, and when normal medical ethical decision making, is not appropriate anymore.
And in terms of other influencing kind of factors, what about things like research in the ICU, or potentially healthcare workers been admitted to the ICU? Those are issues that seem to have come up in the literature.
Yeah, I mean, they're quite difficult issues, I suppose. I think the figures from Ireland at the moment, they reckon about 23% of healthcare workers who have become infected have gotten it at work, and the others have picked it up in the community, or in their social group. That's a kind of a difficult one. In terms of research, I think it's really important that research happens during a pandemic. If you look at the first SARS pandemic, all kinds of different treatments which are being tried now were tried then, but there was no coherent research policy, and we don't really know if or whether any of them work or not. So in fact, I think it's really important that research continue during a pandemic, because you get large numbers of patients with the same disease, and it may become rapidly possible to actually identify which treatments work. And there's one, the study which is running in a couple of centres in Ireland. One is one called REMAP-CAP, which is it's a community-acquired pneumonia study, but it flips to a pandemic study, and there are several arms to it. I think one of the difficulties with research is that it's often viewed as you're either treating the patient or you're doing research, and in fact you should be doing both at the same time and trying to learn while you're treating the patient. And I think these multifactorial trials kind of get over that, in that the REMAP-CAP trial, I think about 95% of the people who are in the trial will get some sort of intervention rather than just placebo, and that kind of makes it easier for people to kind of get their head around the fact that they are in a trial, but they are getting active treatment. So I think research is really important. There is mention of allocation of resource to healthcare workers, because they may need to be they're required to get back onto the front line as soon as they can. I'm not sure whether everyone would agree with that. I think it's a controversial one, but that is there in the Department of Health guidance. Yeah.
And John, how do you ensure kind of the fair application of these principles, across not only internally but across the country, and ensuring that these are applied consistency on a national basis?
It's very difficult, and I think that there was a lot of talk initially about scoring systems, but there is no verified, rigid scoring system that you can use, and apply to patients who do have COVID and patients who don't have COVID. And I think it comes down to individual decision making, as Emer has said. That's what we do well. Every patient's unique. You can't actually score for it. Some of the North American documents do actually provide a sort of scoring system, or they certainly categorize patients based on things like SOFA scores, which is a measure of acute organ dysfunction, and based on other things. But there are difficulties with those, and I think really my sense is that this process is being actually done fairly consistently throughout the country. Certainly in the CELTA group, we regularly speak to colleagues in the other CELTA hospitals, which are, from Letterkenny down to Galway, and I think my sense of it is that it is being applied fairly consistently, with some tools which are, some guideline tools, but certainly there isn't any good rigid way of actually differentiating between who's appropriate and who's not. It comes down to every individual case is unique.
And I think, like Miriam mentioned there earlier, we can share any of these resources that you mentioned. Is there anything you'd particularly want to point to? I think there was a very nice piece in the New England Journal a few weeks ago on fairness and allocation of resources.
There was an editorial in the New England Journal about it, and they referenced a number of documents, including there's a New York document which used SOFA score. So again, very, very sick patients might get into a category where you might not admit them to intensive care. But I think there are difficulties with those, and I do think there are cultural differences between North America and Ireland, which actually come across in some of the triage documents. The best one I've seen, as far as I'm aware, is a Canadian document, which was at least, now these documents were drawn up for pandemic influenza. So they were drawn up, in the cold light of day, without the sense of urgency and I suppose panic to a degree that we have I wouldn't say panic, but there is a degree of urgency and a lack of time to actually sit down and draw up one of these documents. So I think the Canadian document was quite good, but I think really at the end of the day, it's about multifaceted assessment of patients, having a good idea about what impacts their short-term survival and about what impacts their long-term survival. And getting the patients who hopefully getting all patients who have potential to benefit from intensive care to intensive care, and hopefully if we do get into a situation where we're out of resource, where we can do that fairly and consistently across the country. I mean, to that end, there is a dashboard where you can find out where there are intensive care beds throughout the country, so you can find out quickly if we are truly out of resource or whether transport is an option. And so that's one thing that got up and running very quickly, and it's quite useful.
Thanks, that's fantastic. And I think one of the themes coming through from the last few of our webinars has been the importance of communication here, obviously with families and patients where possible, but also the importance of multidisciplinary working. And even though there are some difficulties with that at the moment, it's still possible, and it seems critical even with the best of ethical guidance. I might hand over there to Tina and Caroline just to see if we have any questions at this stage.
Hello, John. This is Tina here.
Hi, Tina.
How are you? There's a question in for Emer around how are the frailty criteria to be applied to people with stable long-term disabilities, including those who may be non-verbal. Is there any comment that you'd like to make on that, Emer?
Yes, and I suppose it's not applied. So I suppose the clinical frailty scale, which has been used in the NICE guidelines, and I suppose when we saw this, I suppose we reacted quite quickly here to say that we would not be using it in the same way here. And certainly we issued a document here to inform people how to use the clinical frailty scale correctly. And certainly this is a scale for use in older people. It initially was a risk stratification tool, so for only older people older than 65. And in the initial studies, it was mainly for people in their 80s. And initially it was used as a risk stratification tool and certainly not anything else. And it's just increasingly becoming used as a screening tool to identify frailty. But it certainly isn't a screening tool by itself to identify someone for escalation of care. And I think that's very important to point out, that people almost overestimate frailty when they see someone. So that's why it's very important, as I was discussing earlier, to use frailty as part of a multi-dimensional assessment, but it certainly isn't of use in people with long-term disabilities or chronic conditions that have that they are non-verbal for now at the moment. So it's not suitable for use, and we have emphasized that in our document here.
And I suppose a follow-up question, which again is paying tribute to the tool that you have there. What kind of organisational supports or additional organisational supports do you need to be able to support this type of person-centred decision making?
To be honest, I think in terms of implementing it on the ground, I think the collegiality and I suppose the interest and the want of all the healthcare staff on the ground in the hospital has been enormous, really, in trying to implement this and get it off the ground. My own registrar, Dr. Maloney, has done an education video in terms of supporting people and how to use this tool. certainly in reference to what John was talking about earlier on in terms of ethical decisions. If you come to resource depletion, I think it would be very important to have an ethical framework or a structure, that would be national or even group-wide, that would support people when such decisions would have to be made, if they ever have to be made.
And John, would you like to come in on that discussion?
Yeah, I mean, that's entirely appropriate. I suppose in terms of stratifying people's risk and likelihood of survival in COVID-19, there's only one multivariate study out there. It's 191 patients from China. It is possible to convert it into a scoring system, but it's only applicable to COVID-19 patients, which presents an immediate problem. So again, it's a difficult situation. I think it's important to get an intensive care, involvement in the multidisciplinary decision making at the point when the patient's actually able to express an opinion, and because that will change as if we get to an out of resource context, and B, I suppose we do have an insight into what the burden of care is, and what people have to go through, in particular to wean off mechanical ventilation. It's quite an arduous process, especially if you're frail and elderly and unable to do it quickly. I do think the intensive care data in patients over the age of 80 certainly suggests that appropriate use of the clinical frailty score is a better measure of outcome than chronological age. So it is backed up by a fair bit of outcome data in the intensive care unit, but there are difficulties in applying it properly, and I would agree you can't just use it in isolation from other comorbidities and stuff.
Yeah.
I think then the other discussion or comments that are coming in are in relation to patients' rights, and I suppose the question there around sorry, I've just lost my question there. The question around human rights. Is there any comment that either of you would like to make around that?
No, just I suppose to say, I think you need to get the best advice you can before you can make a decision, and that needs to be weighed in. And people obviously have a right to direct their own. Well, they have a right to kind of make their own decisions, and they have autonomy. I guess though, if you get it to an out of resource situation, things can change. It's not exactly the same. You may not be able to provide a resource that you want to provide, and it becomes again a community-based decision rather than a medical decision. And it becomes a kind of societal thing rather than an individual human rights thing. As I said, hopefully we won't get there, but if we do, that is where we'll be.
Okay. Caroline, that's all of the questions that we have in at the moment. So unless there's other comments that people would like to pick up on the panel themselves.
Tina, for that. Thank you. So over to our panel, is there any final comments or thoughts that you might like to share based on how the conversation has gone?
Yeah, it's very difficult for patients at the moment. They can't have visitors, and that's difficult for families because they don't know what's going on. And generally, if you don't know what's going on, you tend to presume the worst is happening, and that it's actually harder to communicate with families at the moment. When patients are in the intensive care unit, it's quite a problem. It's a problem we've never had before, and we're trying to get around it. There are various ways of getting around it. At the moment, we have a system whereby family can actually do a virtual visit and teleconference with patients in the unit. But it's difficult for families. It's difficult for the healthcare staff trying to communicate with families outside of the intensive care unit because it tends to be an ongoing discussion. As I said, most patients who come to intensive care at this stage, they are recovering, they are getting better, but clearly those who are not, it just makes it extra difficult and extra traumatic on families not to be able to go in and even to see their loved one face to face or see the doctor face to face. So that's an additional complication that this pandemic has given to us.
But even that's important, John, isn't it, to preempt that to some degree, and to, like you said, there are perhaps technologies there that can be used that we're all still learning about, you know, to ensure that that communication does happen, and to try and get in there as early as possible with that communication.
Yeah, I think you're right, and you know, it doesn't seem to make much sense, but being able to video conference with the sedated, intubated relative who's just, you know, on mechanical ventilation, you wouldn't think that would actually be of much value, but it probably is, we think. And we also know that families of patients, both patients and their families, tend to, you know, get fairly commonly get symptoms of post-traumatic distress disorder after a patient has been in the intensive care unit, whether they've gotten better or not. So it is difficult, and I think you tend to believe the worst when you can't see what's going on. But you know, it's we try to phone the families every day as well if we get time, just to keep them updated on what's going on. And I think it's very important to try and keep communication open, but it's a lot easier when you can walk out and see somebody face to face and have a normal human interaction with them.
I think there's an aspect that I'd just like to mention. Actually, Emer and I were discussing earlier, and I'd appreciate Emer's opinion on we haven't really discussed actually CPR itself. And there was a very interesting article yesterday by Dr. Rachel Clark in The Guardian, and I'm really hoping that it reassured people about CPR, and in particular what do not resuscitation actually means. Emer, would you like to have any comment on that? Or?
Yeah, I think with everything, with all these treatments that we talk about, I think it's very important to emphasize that everybody who comes into hospital is going to, or anybody who is at home, you know, sick from anything else, is going to get the treatment that they need and the care that they need. You know, no matter where they are, they will receive it. And I think it's very important to emphasize that there are different treatments, you know, that people can be given when they're in hospital. But it's very important as well, as John is saying, you actually need to be very informative about kind of what the benefits of the treatments are and what the burdens of the treatment are. And as treatments become more complex, the burdens become more. And we really need to explain this, that there isn't any life-saving treatment that people are being denied, actually. You know, there is no life-saving treatment for this illness. There are just different treatments that we can give you to support your body to get better from this illness. And that is really what we're trying to do throughout the whole system, from the community doing their social distancing, to GPs, to hospitals. And that's really, you know, the overall aim of this. So I think the rhetoric and the language around, you know, ventilation as a life-saving treatment, or CPR, I think it's, when you say they're not for ventilation or not for CPR, it is implying to people, and people are believing that it means that there's not going to be any care. And I would actually say that it's actually, there's been a lot of thought and decision being put into care when those decisions are made. So these people are actually getting, you know, a very good level of care from all the people that are looking after them.
Just to echo that, and you know, the other point, I suppose, is most people in their 80s who get this disease will actually survive it, is the other thing that just seems to be missing out there. The point is, if you get to the point of needing mechanical ventilation, it offers you very little in terms of improving your chances of long-term meaningful recovery. But yeah, I think that is an important point. And we do admit people to the intensive care unit who are not for CPR, because there are other treatments other than CPR, which may be effective, and or may not, but may be effective. And you know, it's individual treatment decisions which are made. So mechanical ventilation, CPR, inotropes, whatever. It's a bit more complex than having you're either for nothing or you're for everything, and everybody will get appropriate care whether or not they're for escalation.
Yeah. Okay. Any other comments from the panel? Do you want to pick up on any themes from the panel?
No, I think that was a fantastic discussion. Thank you, folks.
Thank you very much, everybody.
Thank you.
And thank you very much for your time. So some of the key themes that are coming through from this evening's discussion is the whole person-centered, holistic approach to care, and that what's happening in reality is that it's collaboration in practice, and it's working for patient care, which is what we're about. That it has a multi-dimensional component to it, and communication is vital. from an ICU resource allocation, when you have capacity, you can do what you can do. The issue then is when you're moving out of capacity and out of resource planning. And there's some useful documentations, as Dr. Bates has described, in relation to what the Irish Medical Council have talked about, and the Department of Health and WHO, and some good information coming out of North America, Canada and Pittsburgh, New York, looking at scarce resource and what do you do when you don't have enough. And I think the really important point that I took as well was the whole thing around research, that research should not suffer. It was a little bit like our conversation on Tuesday around values and actions and how ethics are really important in that. And also then, you know, the whole multifaceted approach to caring for the patient. So you're doing what you normally do well. It's just a very unreal, complicated set of circumstances we're in right now. And that every patient is unique and every patient is given the value that they require in terms of care. And I think back to the point that Miriam was saying earlier on, that patients who sadly lives are cut short by COVID-19, that they die peacefully, naturally and appropriately. But in all of that, there's the whole issue around families, and I was struck by that when John Bates brought that up around the burden and on the staff and on the families and how they communicate with their loved ones. And I was thinking as you were talking, maybe this is another area that we could have as a conversation that matters, and, you know, maybe include some family members as advocates. So I'd like to thank everybody on our panel. I would especially like to thank Dr. Emer Ahern. Thank you so much. We're very grateful for you agreeing to be part of our expert panel tonight, and also for yourself, Dr. John Bates. I see you still in working clothes, and I've no doubt you're extremely busy, so we're very appreciative of you taking time out to come and talk to us tonight. And to John Fitzsimons, who's part of our user group and has been involved in all of our discussions and will continue hopefully to be, and indeed Dr. Miriam Colleran. Our next conversation is planned for next week on Thursday the 16th of April at 6:30, and what we are hoping to do is stay with the theme of ethics, and we're specifically going to look at loss and bereavement in COVID-19. We have additional supports available through a series of video links and podcasts by Professor Michael West, Senior Visiting Fellow from the King's Fund and Organisational Psychology at Lancaster University. And we would be very grateful if our audience had any suggestions that you email them to rcsileadership@rcsi.com. So I'd like to thank you all, our listeners, and especially our expert panel. Thank you so much. Good night.
Thank you very much.
Thank you.
Thanks, Caroline.
Thank you.
Thanks.
Thank you.
Good night,
Thank you.
folks.
Thanks very much.